Bobby Jefferson. Bobby Jefferson is the director for the Center for Informatics at the Futures Group. Bobby is a mobile health technologist, integrating technology development, infrastructure, and policy. Mr. Jefferson has led the design of innovative mobile health, e-health, and DHIS2 solutions. He's created secure health cloud solutions and a national data warehouse, a business intelligence running big data analytics for 4 countries. He's established national information and communication technology policy regulations. Mr. Jefferson sits on the technical advisory panel for the Human Development Innovation Fund, a social innovation impact fund in Tanzania. So in this session entitled Mobile Technology for Global Health, Lessons from the Field, Bobby will share some technical and policy informatics lessons for using mobile technology in the field and explore future directions. And he's a nice guy.
Yeah, thank you. That's an extremely long intro. I appreciate that. How much time do I have? I want to make sure we get back on time. So
about 25 minutes and
okay.
Then 5 minutes for questions. If we
all right.
Okay.
So just alert me if I go over time or I exceed. So again, I'm Bobby Jefferson. I'm really glad that you're still awake, you're still here, so we'll make this interactive as possible. So my company, GRM Futures, I'm the director. We were here on Main Street, so those of you who are nearby, welcome to visit. I run the ICT or Innovations Group within the organization, and that means I have about 130 software engineers, a few hardware people, medical, clinical, epi, who are sitting in the field. Very few of my staff actually sit in the US. So a lot of the solutions, a lot of the technology I refer to is because my staff actually sit in Haiti, Guatemala, India, Afghanistan, Indonesia, South Africa. So it's really them and their work that I'll be representing, right? So what you're hearing from me is, typically you go to these conferences and people put these fantastic PowerPoints up and how fantastic that their technology works. And then what I do is I go, great, I go to rural, Nigeria, I hop on a plane, and go visit that site. So this is a Gimbo Hospital in rural Nigeria. Go there quite frequently. It has no power, so you've heard about the power issues. What you didn't hear is that they also have very little staff, no internet, and can't afford an iPad or an iPhone to save their life. So all you great apps developers, how do you address supporting a clinic or hospital there with your app? And then how do you do a help desk call for when she can't figure out how your intuitive app works and where the buttons are, right? So these are the realities that we face, right? When you're trying to work in the global environment, where you're trying to take your solutions and expand it to the further larger world. But let's say you do have a way to actually, address the issue of being a help desk and resolve it. So, you have to get on one of these, sorry, it's going too quickly, there. One of these 4-wheel drive vehicles if it's rainy season, and actually go to that clinic, and if you can make it, then you can, help her out and answer her question around, many of the times, most of the apps, that we develop, we put these funky, very difficult to decipher messages about what's wrong, all that sort of thing. So we try very hard in our work to make things a little bit easier as possible. And let me see. Oh, I see Adam Curry from BD. Can you verify for me that this is, this is correct or not? I think Adam went on a trip. So other times it might be easier to have a van, and you put your solution in a van, and then have that van go to the village. We're doing this in Uttar Pradesh in India, where there's a fixed day, fixed time where people know they can get medical services. And so then all the fancy technologies, all of that, it just fits in a van. So that makes it a little bit easier instead of just having things in a health facility. So both the mobile device can be mobile and the actual transport device itself. So, I'm very happy for those of you who have good ideas that actually work in a mobile van without internet, during rainy season, please see me. I'm happy to collaborate on those types of solutions that you have. Typically what we see is this is rural Tanzania, so what they're using there are the low-end phones. And one of the low-end phones, this is one of the Samsung, one of the older models, but this one is solar powered. So on the back end has a solar panel. So they can use it for about 4 days without having to recharge. So I'm very big at doing a few things. One is using technology that people already have in the field. It doesn't quite make sense to go to a clinic or a hospital and say, hey, I've got this great new app, I've got this great new technology, I'm going to buy all of you new iPads. Right? Because the iPad itself is worth more than the salary they're receiving for that month. It makes them the target for criminals who want to steal that iPad. I've had to replace many, many laptops, computers, tablets for my staff simply because they're carrying an inexpensive, what we consider tablet, on the bus and someone's stealing it from them. So I'm a big believer in doing the opposite. Whatever technology people have in their hand, trying to use that as the source of the solution rather than trying to introduce yet another solution that, 3 years from now, the desktop won't work, it has an old operating system, and we've all moved on. So, I think that's an important aspect of that user-centered design that we talked about earlier. This is one solution we're using in rural Uganda. Again, I put the websites down so that way those of you who are researchers, you can actually go and find this out. But it has a solar panel on the back of the Netbook. So it allows 12 to 14 hours of use without having to recharge, and then the doctors just put it up in the sun to recharge. And this works fine, this works well, it's not high tech, but you can buy it in Africa. You can buy it in Uganda, Kenya, West Africa. Why that's important is because of the security, the maintenance, the support, all comes along with that when you purchase it. So those of you who are new to international health, if you take your fancy technology, iPad, iPod, Samsung Galaxy, and you port it over international borders, the warranties in the US don't apply when you need to repair it or get it fixed, either in Southeast Asia or in Africa. So I very much try to encourage people to use and buy technologies that are obtainable in the country. Because then you get the warranty, the service, the support, everything that you need to make it sustainable way after we're gone. Typically, we'll have these great ideas. We sit here, we've got these fantastic ideas, and our funding is really good. And then the students graduate. And then the NGO groups, they lose their funding. But yet, the clinics that we're supporting, they still have the technology that you convince the staff to use. And the maintenance, the support, and all that, the ministry doesn't know about it. The NGO group doesn't have any more money to fund it. There was an instance in which one group set up a patient reminder. So HIV patients have to have good adherence. So you heard that earlier. So they set up a nice mobile patient reminder system. Fantastic. And then they were sending out about 150, 200 mobile reminders each day. After the NGO lost their funding, of course, the SMS messages stopped because the NGO was the group that was paying for the airtime to send out those messages. So what we then had my staff do is we actually worked with the clinic to start including in the clinic's budget the airtime for the messages, right? So finding ways not to introduce new technology, but introduce it so that's a sustainable way, so that clinics can use it way after we're gone. So that's why I'm a big supporter of what's called the Open Digital Principles for Digital Development. And again, many of the donors, USAID, World Bank, all subscribe to this, which just says, if you're going to design something, design it with users in mind. Use things such that your data can be open and shared. And then this new concept World Bank is calling open innovation as well. So you can, again, go online, look at the principles, and we're a very strong supporter of that. We've developed a number of applications as well that are all open source, freely available for hospitals, clinics, electronic medical records, everyone to use. But what's more important, and this is based on 10, 12 years of experience doing open source in the field, which is it needs to sit and reside in an ecosystem. So let's say you introduce a new software to that clinic. So this clicker, EMR system fits at the facility level. But what we made sure is that we can talk to IntraHealth's IRIS system, all right? Because IntraHealth is a fantastic system, so we'll be able to talk to that. And then the system can talk to all the mobile health solutions that are out there. So there's a number of open source mobile health solutions from Frontline, SMS, Medic SMS. Of course, Damaji has a ComCare. But there's a lot of mobile health solutions out there. So if you're designing yet another mobile app, I strongly please urge you to recommend to base it on standards, whether or not it's an ODK, Open Data Kit standard. So that way your data information can be shared and not just being a single vertical within a clinic. we have absolutely seen on the HIV clinic, a nurse has an HIV phone. And now she's got a TB program, so she's got her TB phone. And now she's got another around PMTC antenatal care, she's got yet a third phone. So we've seen repeatedly these vertical programs coming in where they're capturing the same data, the same reports, and not being shared. So we have an opportunity when you're looking at designing solutions to use standards and interoperability standards that allow them to talk together. And then the same thing with supply chain management and being able to talk to other systems as well. One of the things that we're encouraging and that we're using in ours is, of course, MOOC. This is really transforming a lot of the universities, especially overseas. So the question is, what if a healthcare worker, if she can train at her desk or use a mobile phone? One of the reasons why we like MOOC and we like e-learning is I like it from a cost perspective. Typically, you'll have let's say you're training a healthcare worker, community health care worker, and it's a 5-day training. So you call everyone from the region, they go to a hotel, and they're sitting there for 5 days, the intro to your solution, and then by the second day, you get more advanced concepts. So what we do is we've changed that. We actually have people go through an e-learning, a MOOC course first. They learn the basics, and then after they've passed a grade of 80% or better, then we hold the training. What that does is it allows us to have individuals who already start the training from reducing it from a 5-day training down to a 3-day training, because the first 2 days that we spent with the intros, they're now learning on their own, and when they're prepared and ready for the topics, the normal didactic training, then they attend. So we're doing this in Guatemala, or at the ministry in Guatemala, to be able to roll out. We're doing some data visualization training with them at the across 21 ministries. So both being able to reduce costs, and because it's just easier to do those basic trainings on your phone or your tablet or at home. And again, once they pass that training with the MOOC model 80%, then they're eligible now to attend the normal regular trainings. So it's sort of that mixed model, which we think is a good approach. Just like everyone else, we're strong supporters. I'm a strong supporter of using tablets and devices and Android. But my reasoning is we're managing right now about 4,000 hospitals and clinics, 1,800 clinics in Tanzania, another 800 in Kenya, different countries. And so every time I go to a hospital, they say, Bobby, buy me computers, because the hospitals want to be automated, just like the ones in the US. So the question is, how much does a desktop computer cost? Did someone tell me the cost of a desktop computer? Just a quick idea for a desktop computer. Do you know? $1,000. Yeah, someone knows the answer. Okay. $400 for the desktop. Okay, how much does Microsoft Windows cost? Because you have the computer and now you need Windows, right? Okay, yeah, say 8. How much does that Microsoft Office cost? From 80 to 300 bucks, I've heard, for Microsoft Office, right? So either way, as you add it up, just to do Control-Alt-Delete and put information into a spreadsheet, that costs $1,000 to do that, okay? So if you're trying to automate an entire hospital, it's that same $1,000, I can go purchase 8 to 10 tablets. How much does Android operating system cost? Well, that's open source and free. How much does OpenOffice cost? Well, that's open source and free. And our software and other people's software, that's open and free. So I reduced the ROI, I reduced the cost for a clinic to maintain and manage a software solution by moving towards a tablet type solution. So that's the reason why we're using it. It's not really because it's fancy technology. It's really because now the clinic, if that tablet gets lost, they can afford in their own budget to buy another one for $75 or $100 US. Rather than trying to say, hey, donor, please don't give us $1,000 for another computer that was stolen, right? So this is one of the reasons why we're doing that. But, what if, of course, you have a tablet and you're interacting with it. So if you're a clinician in the field, you've been taught, the SOAP model, SOAP process, where you're engaging the patient, you're coming up with your assessment, and designing a protocol, and then, you're interacting with the patient. So you're interacting with the patient, you're typing something in. You're interacting with the patient, you're typing something in. So that tends to be somewhat distracting. I can tell you, absolutely distracting. So one of the things that we would like to see is, what if your data was hands-free, right? So what we're hearing from the field is, hey, Bobby, how to get, my hands free so I don't have to continue interacting with these devices. So we're also working, just like everyone else, on using wearable devices to have the patient information to sort of begin to free up the nurses and the clinicians' hands. So I got my team in South Africa looking at this, other people are looking at this. Of course, Google Glass isn't being produced anymore, but we have other similar Google Glass type knockoffs that we've been using as well. But the idea is still the same, is how to free up the patient, the clinicians from doing their traditional writing of paper. How to then, when you're having a patient who's visiting, how do you know who she is? How do you know who he is? How do you know who the baby are? Many of the countries, they do not have social security numbers. They do not have any identification whatsoever. So we've been working with some folks, Dr. Rich Fletcher from MIT Media Lab, to use your mobile phone as a palm biometric scanner to be able to uniquely identify patients and others who are coming in to the hospital and clinic. One of the more important aspects of doing global health work is that, you really can't, if you go to Haiti, you go to Nigeria, you ask to see their passport, you ask to see their identification. They have 3 or 4 or 5 different identifications, 3 or 4 or 5 different names. They share identification from other people. So to be able to uniquely identify people is a huge challenge, huge challenge. So that's one of the things we've been working on, and others are working on as well. So if you have ideas around, unique biometrics, I'm definitely open to hearing them, especially things that do not require or depend on power. Again, I showed you earlier, if you have a USD device or a 2D fingerprinting device and there's no power for 8 hours, it's not useful. The clinic still has to work. Right, so again, that's what we're looking at around mobile devices. And again, as the tablets become much more ubiquitous, especially in India, Dr. Karnath, who's supporting the Public Health Foundation of India, he's designed pulse oximeters and being able to put diagnostic devices onto your tablet and empower the community health workers when she's visiting the clinic to be able to take just basic blood pressure, blood pressure, vital signs of infants and babies for neonatal care. So just being able to think about how to empower community health workers to obtain more data so that way, they'll have information a lot quicker. Many of the countries, the community health workers are volunteers and they're not paid. So, okay, they're there today, tomorrow, I worked with one group, I won't mention who, they say they have 8,000 community health volunteers. I said, fantastic. And then, when you show up, 50% of them didn't show up that day. The other 50%, they found another job. And then you have to start your training all over again. That's the MOOC model, right? To be able to train lots of people rapidly. So this is what we see quite often in developing world, emerging markets. So now you're the clinician, you prescribe the drug and tell the patient to go pick it up. So of course you're hoping you don't have no insight as to if there's actually that drug in stock at the pharmacy for that patient to pick up. So one of the things that we're doing, as others are doing, is be able to track those stockouts, making sure that clinicians have knowledge and the physicians and pharmacists have knowledge about which drugs and meds they actually have on stock. Because believe it or not, it's absolutely still a challenge today. There's a huge issue with stockouts. And I showed you how long the patients had to come and walk just to get to that clinic. So she walks the 2 kilometers, gets to the clinic, and there's no HIV drugs, there's no meds. And then she's lost a day away from her family. She lost a day if they're an itinerant farmer, and they have to come back. So this is a huge issue that many of the folks in the development community are trying to address. That's why I mentioned earlier, looking at people like Pepsi and Coca-Cola and Amazon to see how are they addressing with their supply chain management system that can be applied to the health side. Now, within that, there's another issue that doesn't sort of come up in the US, but is absolutely a problem, which is, okay, how do you know that the medicine you're taking is actually real? How do you know that it's really, truly active ingredient? There's, quite a few medicines available in Southeast Asia and Africa. But the problem becomes there's only one person in the entire supply chain that cares that you're taking the right medicine. And who is that? Do you know who's? I'll tell you, it's not the pharmacist. I'll tell you, it's not the clinic. I will tell you, it's not the pharmacy, the clinic data warehouse. The only person that really cares they're taking the right medicine is you, and it's me. Right? We're the ones sick. We're the ones that want to take the right medicine. So there's a group out of Boston called Sproxel, and they have a nice technology around detecting counterfeit medication. Again, counterfeit medication is a tremendous, tremendous issue, both at regular pharmacies in these countries and the informal pharmacies. So they have a unique code associated with the blister pack. So on the blister pack, everyone's used to doing scratch-offs. So you can do a scratch-off, you type in the number to SMS, and it confirms whether or not what medicine you're taking is counterfeit or not. So you can go to Sproxel's site. They keep a running total for the number of SMS requests they receive. You'll see it's in the hundreds of millions, tens of millions already. And they're working in places that are the toughest, like Nigeria, which has lots of counterfeit. Mexico, tremendous amount of counterfeit. And they've expanded beyond the pharmacy to now luxury products. So how do you ensure that they're doing it for women who are buying these Coach bags that are like $2,000 US? How do you ensure that you're not buying a knockoff, right? So you need, as an independent consumer, a way to verify that, yeah, I'm really spending $2,000 on a genuine product. So they've expanded beyond just meds to luxury goods and other items. So it's another good solution. The other, question is, what if patients can report when they went to the clinic that there's a lack of medicine? So there's a number of open source cloud sourcing applications that they can text, mobile, IVRS. So please let's not forget one of the most important data collection devices is actually by voice. Patients actually like to hear a nurse's voice occasionally, not just by sending these SMS texts. So we've set up and talked to a number of vendors around sending up a reporting system so that when patients go pick up their drugs, it's not available, that they can instantly report. And so this is one in South Africa where they've been reporting stock outages around HIV drugs and malaria drugs and that sort of thing. And then we partner up, and I keep emphasizing partnering with private sector companies. We're partnered up with IBM, with a few others, and I think that's an important part. Another technology we're involved in is, of course, UAV and drones. People are thinking about that for cold chain usage, stock resupply. This is our team, one of our team members from South Africa who actually went to drone training, so that way the drone doesn't end up on the White House lawn. So, many of the countries now are wrestling with what's the policy, what's the regulatory policy issues with UAVs. If it's under the military of defense, I can absolutely tell you it's much more restrictive. Whereas if you can keep the policies around drone usage to be on the Ministry of Transport and Aviation, then it becomes much more encouraging. Because they see the value of being able to do, to protect their wildlife, stock resupplies, that sort of thing. So we're teamed up with a medical device company somewhere here in the area to be able to look at that type of problem. So that we're actually addressing this right now. And then, of course, people are really excited about 3D printers. Okay, and we're excited too. I've been told that 3D printers is the equivalent of Star Trek's replicators, where you can just push the button and automatically these new devices come out. So, I've had my team actually start working with the clinics to see what's the good, strong use cases for 3D printers. Of course, we all have heard about, developing limbs and producing limbs and all that sort of thing. But when you get really to those rural clinics, what they really want are just some basic things. They want the 3D printer to produce, just like clamps, because they run out of supplies, or just some basic medical devices. One clinic, what they asked for was that they have a wall, and the wall had lots of power cords coming out, and electrical cords. They just wanted to print off a wall socket just to be able to cover that. Or one clinic just wants to be able to print off the toys, just little basic toys, for the pediatric age patients who are coming in to be able to just play with. So when you step back and look at the use cases, they tend to be very, very simple, straightforward, rather than the advanced, sort of sexy technology that we're thinking here at home. So that's what we're doing as well. We're doing some 3D printing, and we'll publish a few papers and have some data available shortly around that. So Having said that, I always like to put my money where the mouth is, or wherever that expression is. So we're supporting an innovation fund. So for those of you who have fantastic ideas, and an idea is new so we're supporting under DFID, so that's the UK. We'll support innovative ideas at the pilot stage we'll fund about $700,000 US, and then for pilot to scale, we'll provide funding for about $3 million US. So that way and to go from pilot to scale, we'll give you business training, sales training, we'll give you all the mentoring and training that's necessary to move that. No, I didn't put it then. Then we also have a second fund that's for Rwanda, Uganda, Kenya, and a few other countries, targeting women entrepreneurs. We see the gap in women entrepreneurs, so we're targeting a special fund just for that. It's supported by DFID and Nike. And that is to encourage women entrepreneurs along the same lines, and we'll provide not just funding, but also business assistance as well. Being able to help them grow their business as well. So that's my presentation, and if you have any questions, I'm still around. Thank you.
Thank you very much. That was a great discussion. Do we have any questions from the audience? I know it's late in the day. You'll be around for the meet and greet here afterwards, right? So,
absolutely, yeah.
So please come up and ask some questions. And I'm going to go ahead and now introduce Dr. Gary Bennett. Thank you so much. Thank you so much. So we have closing remarks by Dr. Gary Bennett. Dr. Bennett is a professor of psychology and neuroscience, global health and medicine at Duke University. He directs the Duke Global Digital Health Science Center and the Duke Obesity Prevention Program. Dr. Bennett's research program designs, tests, and disseminates digital health obesity treatments for medically vulnerable populations. He is well published over 100 articles at this point, probably just published one today, I think. He co-founded Crimson Health Solutions, which developed evidence-based behavior change interventions for the disease management sector. And Health Dialogue acquired Crimson in 2007. He recently also co-founded Scale Down, and you'll be able to learn a little bit about that from him if you get a chance to talk with him. So it is my pleasure to introduce Dr. Gary.
Well, I appreciate the introduction, but I promise you that I'm not going to speak for very long because it's the end of the day, and I know all of us are getting ready to get to the meetup this afternoon. So there is the Triangle mHealth meetup right after this, and I hope all of you will attend. But I thought this was just a fantastic gathering today, and I just want to start out by acknowledging the mHealth at Duke co-founders, Bernard and Joe. Can we give them a hand for putting this together? Whenever students ask, sort of why is it that you do what you do, one of the things I often say is I love being able to sit at my desk and think of an idea and then at some point later see it come to fruition. That's just the most fun part of my job. So I can't imagine what you guys were thinking a couple of years ago and dreaming this up and turning around and seeing all these folks here. So, I appreciate the vision you guys have put into this. These are always kind of fun gatherings for me because I grew up at a time when, I would sort of be sitting upstairs in my room waiting desperately for my parents to get off the telephone so I could get on the internet, and so the idea now that we're talking about people being connected in places like sub-Saharan Africa to the internet via their telephones is just absolutely mind-blowing to me. But this is sort of a fun and point, I think, in time of mHealth science. I don't think there's been some mention today about HIMSS, and people know what HIMSS is? Okay, so HIMSS is a large, predominantly industry gathering that's occurring right now. There are a variety of HIMSS stakeholders. But if we were in Chicago right now, Monday, Tuesday, some folks have flown down from HIMSS, there would be tens of thousands of industry folks in the area of digital health and mHealth science walking around talking about the latest, greatest, and newest innovations. And here we are in the science community in Durham, North Carolina, an altogether better place with better food, I think. Maybe not better weather today, but we're struggling with many of the same issues. And I think that we should take a second and really contend with that. And really struggle with this question of what is our unique value proposition in the mHealth science community. There's been a lot of discussion today about the pace of technology, and I don't think there's any question that the pace of technology outpaces our traditional scientific infrastructure, outpaces our ability to get grants, do research, and get them into peer-reviewed journals for people to read. Right? Things are happening at a very, very rapid pace. So what is it that we offer in this broader mHealth and digital health market? And that's something I've been struggling with a lot as a person who is committed to my scientific research, but also spends time in the industry community too. I'm sometimes struck by just the differences in the expectations about the amount of time that it takes to get this stuff up and running. And I struggle a lot with thinking, what is it that we do that you can't do on the industry side? And I think today, one of the things I've been hearing, I heard a couple of answers today, and I just thought I would offer them as points for discussion. I think this really started with Bernard's talk, where Bernard, I think, really challenged us to think about mHealth as being a part of a broader set of interventions that we might leverage to contend with bigger community health problems. And I think that was parroted to some degree with what Kevin was saying as well. We really need to think about getting beyond the app and focusing more on communities. And this is something that we're passionate about at Duke Digital Health, where our motto is essentially reducing health disparities using digital health. I think Bobby's talk is a great example of the ways in which we might use these new technologies to cure problems that we've been having a really hard time doing for quite a while. And this strikes me as a great opportunity, and Bobby illustrated lots of the challenges of getting the work done, for us to think about innovation as being something other than bright, shiny, and new, but really bringing new strategies to sometimes older technologies that might exist in the field, new approaches to sometimes older infrastructure that might be in the field to contend with what I think are seemingly intractable community health problems. That's something that I think the science community can do, and it's something that industry is just beginning to get a sense of, but I think it's something that we can make very rapid advances on. There's been a lot of discussion about engagement today, and this is a pet topic of mine. There's sort of a big, I call it the rule of 70, the big engagement problem in the consumer app space, and that rule of 70 goes something like this. Only 70% of people don't download any new apps each month. So if you're making an app this weekend or here in the audience and you're planning on releasing it, you're pretty much likely that no one's going to download it. And if they do download it, the likelihood is that they won't open it. 70% of people only open an app one time. And then the third part of the rule of 70 is 70% of people's time, app use, is spent in the top 3 apps. And the top app is Facebook. We heard a little bit earlier today that, I think, what was it, Damien? It was Facebook. The Facebook app has 70% retention over 1 month?
Yeah, WhatsApp.
Oh, WhatsApp. So, okay. So there are, for the most part, it's really the big apps, the ones that we know of, the ones that are probably on all of our phones. These are the apps that are getting the most amount of engagement. And the real question is, what do we do about the rest of them? What do we do about health apps, which are frankly not downloaded very often particularly from the Apple iTunes store right now? What do we do to get our users to engage? And this is a challenge that I think the science community has been thinking about for quite a long time. Because the fact is, if you look at our trials, and if you look at many of the trials for the folks that I've seen here on the panels and in the audience today, a lot of us do pretty well at engagement. A lot of us, particularly those of you who are doing behavioral interventions, frequently get in 70 to 80% engagement rates on trials. Kevin Patrick gets very high rates of daily utilization of his text messaging intervention. He offered it as a throwaway line a little bit earlier on the panel, but he said he's texting people 2 to 5 times a day, every day for a year. That's absolutely stunning and would absolutely confound a lot of my industry colleagues. So what is the special sauce that Kevin is using? We get 74 to 80% retention in medically vulnerable populations out 2 years in our trials. So it's not Kevin, it's not me. This is what we know to do as behavioral scientists. So what is it that we're doing, and how do we better leverage that and work with our industry colleagues to help to essentially leverage what we're doing and put them into the kinds of apps that might have broader scale? And then the final thing I want to talk about a little bit is this sort of a pivot, and Bernard mentioned it this morning. We've been doing a lot of data collecting for the last 3 or 4 years. Many of us probably have Fitbits on, but the fact is that you could pretty much fill a 365-day calendar with the wearables that were released last year alone. If you look at Xiaomi, they have a wearable that basically replicates all of Fitbit's core functionality for about $12 US. I was just in Singapore, and you could go down to the market and get yourself a wearable that may work for about $7. These things are becoming commodities. They are, I did a blog post a few weeks ago, and I said effectively you'll be able to buy them, at the local drugstore, probably on discount in a year or two. There's nothing special, I think, about a lot of the devices that have entered the consumer market. We've seen massive proliferation of network-connected scales and a wide variety of other types of consumer health and wellness devices. And now we're pivoting away from collecting data, and the real question is, how do we use these data to change people's behaviors, to improve their health? And one of the things I'm most excited about is the discussion that we've been having about data science. There have been lots of questions today about data science. And this is an area where we, I think in the science community, are perfectly positioned. But it's going to require us to some degree, and I think I heard this loud and clear today, to really think about getting beyond the app. One of the things that I noticed was that a lot of times when my research colleagues, when we present our apps, and I do this too, we often say, well, it's not very pretty. And that's an acknowledgement both of the fact that I think that we know that when we're creating our apps, we're really doing these as proof of principles. But it's also a recognition that we know it requires a lot more on the user experience and the user interface side to actually get an app ready for widespread release. It's really beyond the scope of a lot of what we can do on our R01 budgets. And so I think that challenge has to challenge us to think about what are some additional strategies, what are some additional and very unique areas of value that we might be able to add into this market. One of them is data science and utilizing those data to create algorithms, predictive algorithms that might help us to better optimize treatment interventions for patients, might help us to increase engagement, might help us to harmonize data and think about data flows in a more sophisticated way. Lots of discussion about that today. And then I think dealing with the big challenge that Bobby helped us to think about today, which is how do we get beyond the app entirely and use some of these new approaches and particularly interactive voice response, text messaging, other types of strategies to try to help populations that have been difficult for us to reach. So in summary, I'm pretty enthused about our potential in the science community to really add some value, and my hope is that maybe next year HIMSS will decide to come to Durham, since we're going to change Durham from the City of Medicine to the City of mHealth, and then we'll have quite a lot to add to that broader conversation. So thank you very much. I want to, before we walk away, I just want to stop one more time and thank Erica Levine, without whom any of this would be possible. And I want to thank the team at Duke Digital Health who've been helping with logistics. They're all in the back of the room. They're very smiling, nice people back there. So thank all of you for your help. We'll see you all at the Triangle mHealth Gathering. I also want to plug that we have a session coming up on April the 30th with Lana Moriarty, who is from the federal government, and she'll be coming to talk about consumer e-health. That will be happening on Duke's campus. We would love to see all of you there. Thanks again.
So please, is it right next door that we have the reception? Okay, so please head on over next door and give yourself a little reward, have a drink, and then have some more at Will McCabe's if you want. Whatever you want to do. See some more posters. Thank you, everyone.